Okay, welcome Darshak, Rick, and welcome all the people who are joining us. We're off to another Care Ops Hangout. Really looking forward to this discussion. We have the habit, Darshak, of not doing the awkward waiting until people join, but to ask an icebreaker question before we get into the thick of it, and before you do a formal introduction. So you'll be able to impress the audience in a minute with your background and your expertise. But the icebreaker question is really meant to just level the playing field. So the question I have for you is, what was the most embarrassing fashion trend you ever followed?
Oh, wow. I think I would have to say back in college, there's this period of time when I really thought I should have an earring. But I was one of those people, I was unwilling to actually go through with having it pierced. So there was this period of time where you could buy just magnetic ones if you're sort of unsure you wanted to fully commit. So I wore that for a few weeks before I gave up. Yeah.
Okay, that's interesting. For me,
terrible.
it was when I was about 16, 17, I had like short hair, but in peaks, like with a lot of gel in it. When you touched it, it almost hurt. I thought it was cool at the time.
Excellent.
Rick, what about you?
It was a time that I was having like Justin Bieber hair. I was like a big fan of Justin Bieber, and then I had like this Justin Bieber hair, but now I have no hair, so not sure what's best, Justin Bieber hair or no hair. So it's still undecided there.
Okay, great. So let's get started with the actual hangout then. Quick housekeeping. So thanks Darshak for making time, and to everybody joining. There's more than 400 people registered for this hangout, so CareOps has really been taking off in the last couple of months. It's now a community of more than 2,000 people, still growing rapidly. So the session is being recorded, will be shared to everybody who registered, also the people who cannot join live today. There's going, so there's a Q&A obviously with Darshak, but we invite the audience to also list their questions as the conversation is going along in the chat. The chat has been made available, and Rick and I will be co-hosting both this hangout, so monitoring the chat, and if relevant, we will drill deeper into the questions based on the audience's requests. So in a minute, I'm going to ask Rick and Darshak to introduce themselves formally. I will do the same, but we will just start with a quick recap on what CareOps is and why we are here today. Some of you will already have seen that from previous webinars and CareOps events, but there is actually a lot of people who are new to CareOps that registered for the event today. So we will just go through that quickly now, and I'm going to share my screen. Yes. So what is CareOps? It's not a business. It's not a for-profit. It's a community-driven initiative that brings together different roles that often work in silos. So these roles are clinical roles, product, engineering roles, very often as well compliance, regulatory, around building, operating, and continuously improving care flows. And with these care flows, the goal is to drive outcomes improvements for patients and to increase care delivery efficiency. Now, the key word here is care flow. What is a care flow? This concept lives in different organizations under different names. You see some of the names on the screen. Can also be care program, patient journey, clinical workflows. I mean, there's a whole bunch of names, but for CareOps purposes, we've all covered it under the umbrella of the term care flow. Now, the way that these care flows are being built and implemented and improved is broken today. A lot of inputs are gathered from many different sources, ranging from the data you want to capture from your patient to the guidelines you want to follow, or even existing processes that you just want to instantiate. And a lot of teams are spending time mapping out their ideal flows in mostly static tools, and then are given to engineering teams and product and engineering teams who spend significant amounts of time building the technology and embedding those flows into the existing tech stacks, the patient-facing application, the practice management application, the EMR, care management, etc. Now, that's where it gets tough because sometimes it doesn't have all of the inputs needed because people were working in silos. And given that it requires a lot of resources and takes time, a lot of these care organizations end up using the static documents that are the results of those tools, being the Google Docs, the flowcharts and PDFs at the point of care. And very often the feedback loop is missing, and that's crucial because only by continuously capturing the data and using that as an input for your next iteration, we can continuously drive improvements of care delivery. And so CareOps doesn't exist in a void. It relies heavily on other frameworks and methodologies, the biggest one being DevOps. So what DevOps did for software development and is leading to faster software delivery and higher software quality, in essence, CareOps aims to do for care flow development, allowing organizations to get to market faster with their care delivery processes, increase operational efficiency of their teams, which is a very important topic of what we will talk about today, and ultimately drive higher quality of care. So stopping there with the intro, and then what I'd love to do now is first, Rick, if you could introduce yourself formally, I'll do the same, and then we'll give the floor to you, Darshak, and then we will start with our questions.
Great.
Yes, sure. So Rick, NP by training, managing or leading partnerships at AWOL, and it's our mission to make care flows work harder in care teams. And in my spare time, I am the co-author of the CareOps articles.
Hi everyone, I'm Thomas, and I'm co-founder and CEO of AWOL, and I'm also co-author of CareOps together with Rick. Darshak, floor is yours.
Great. Well, it's really nice to see you both. It was nice to actually connect briefly when we were all together at Health a little while ago, meet some people in person. And my impression is this is also an outgrowth of the health tech nerds community, which has been it's been a tremendous source of a lot of kind of great insights for me personally and a number of my colleagues as well. So it's great to be with you all. Should I just start off, maybe give a little bit of my background? Would that be helpful? And maybe a place to start, and then we can go from there.
Absolutely, please.
Sure. So I'm talking to you all. I'm at my home in Boston, Massachusetts, in the USA. I am, my current role is I'm the Global Chief Medical Officer for Babylon, which is, well, I'm sure I'll have a chance to talk about it. But in that role, I oversee our global clinical operations. We have about roughly 1,500 people across the world, primarily delivering clinical services in the UK, US, and Rwanda. And we have, so I oversee all of our clinical operations, clinical care quality, care models, and also our relationships with our product and technology development globally. So and I've been in this role for about 2 years or so. It was exciting. We came here from the UK to the US for a lot of reasons, and also entered and went public on the New York Stock Exchange about a year ago. My background is before coming here, I was at UnitedHealth Group for almost 4.5 years. The first part of my career, I was a chief medical officer at OptumLabs, which is the R&D basis of Optum. So we have one of the largest healthcare data sets in the world. And I was charged with not only the discovery, but also a lot of the work around the opioid crisis, maternal mortality, morbidity, Alzheimer's disease, dementia prevention, and taking those processes across whole enterprise. And the second half of my career there, I was the chief medical officer for UnitedHealthcare at Medicare nationally, overseeing all of our clinical policies and practices. And it's a big organization. It's about $90 billion of revenue per year in the US. It's the largest Medicare program in the US. And I came there, and one of the reasons I'm so excited to think, I bet many of us are really like-minded. Before coming to UnitedHealth Group, I spent 2 years in the Obama administration as the director of prevention and population health at the Center for Medicare and Medicaid Innovation. So that we had all these wonderful opportunities to do new programs across the country. In that capacity, I created the accountable health communities model. So when people talk about social determinants of health and the ways which we screen for them, that came out of work that we started and then nationalized. Certified the diabetes prevention program for national expansion, and also the Million Hearts model. And without getting into too much detail, before that, I was a managing director of the Brookings Institution. It's a think tank in Washington working on federal health policy in support of the Affordable Care Act. And my background, I come at this from, I'm a pediatric cardiologist, was a chair of a department for many years, and I still see patients, and I take care of children with complex congenital heart disease. I'm actually on call this weekend. So I've tried to keep that up, which has been really nice, and I've enjoyed that quite a bit. And if it's helpful, if we ever want to talk about it, I also have a side interest. I'm a writer. I wrote a book, and one of my fun things is one of the articles I wrote for the New York Times was made into an episode of the US TV show House, if any of you have seen that as well. So anyway, lots to talk about. Great to talk to you all. I'm really looking forward to the conversation.
Well, I'm really happy I asked the embarrassing fashion trend question in the beginning, Darshak, because there's a big imposter syndrome risk after hearing that. And I think it's fascinating. You know, I think a lot of people in this hangout that are in the audience, as well as those who are not there, might not realize that some of the things like social determinants of health and many other things, were at the forefront a couple of years ago, and now they're putting those things into practice. So that's great. Yeah. Now, one of our objectives at CareOps is to make things really tangible, to share best practices, really concrete things. So where possible, we're going to stay away from the general platitudes and buzzwords, and so we're also not here to drive policy changes or macro forces. So that means that we're going to start with our Q&A, and sometimes we'll be drilling down into these questions to get into the practical nuggets. So let's kick it off with our first question. The title of today's hangout is evolving from a one-to-one to a one-to-many care model. And so we'd like to hear from you. What does that mean for you and for Babylon?
Yeah. So, I mean, simply put, and this in many ways just retraces my own journey as a career, which is traditionally clinical care was always delivered face-to-face with one individual, a clinician, physician, nurse practitioner, advanced practice clinician who has a specialized body of knowledge working with a patient. And in many ways, that was really how we thought about healthcare for many, many years. But increasingly, first, as we think about while that's a wonderful approach to have that one-to-one in terms of building the personal relationship and also trust, that's something which also is problematic in many ways. And over the years, we've become increasingly cognizant of the challenges around diffusion of quality care broadly, and also the lack of availability of that type of one-to-one intensive resource. So while we think of the one-to-many as something which is really dependent on technology, that really started 30 or 40 years ago, when we think about much more broadly just socializing the way knowledge is dispersed among the clinical community. So even when, in the late 80s, early 1990s, even when you had that one-to-one interaction, recall it was informed by, in the background, people having grand rounds, ability to diffuse information, best practices more broadly, even before technology was widely available. Now, the challenge over the past few years, and what I have spent a lot of time on here, is can technology actually make that better in some way? And can we actually then take advantage of that? And I think that there's a couple ways we think about it, Babylon. And you said to be concrete, I'll mention one. The first is that the one-to-one is predicated on having attention from somebody for a period of time. So I think of the one-to-many, to be really clear, in my mind, it doesn't mean that one clinician is taking care of 50 patients all at once while they're on different screens or something like that. But rather, it's surfacing so that when that attention, which is the most precious resource we have, is the attention of somebody, it's actually fully focused and used in the most efficient way possible. So what that means for us, for example, is digital triage for clinicians when people start off. So can we collect information and baseline, pre-visit flows ahead of time? We spend a lot of time on that. That information then will go to the clinician. In addition to that, digital triage, so that when there's simple questions, for example, medication refills, laboratory review, so forth, that can be done through self-serve. So what I'm getting at is the one-to-many for me means that they're queued, the patients are organized, that information is there in a seamless way possible, so that when the clinician sees the patient, they have everything they need and can actually work more efficiently. Maybe I'll start with that. And that's sort of, those are the process metrics we typically also track very carefully at Babylon.
Okay, great. So I think we'll touch upon many of the concepts that you now touched upon, but let's mirror that, right? So you just painted kind of an ideal solution. Let's mirror that a bit. And so I think most people understand that transitioning from one-to-one to one-to-many is not as easy as developing an app and putting that app in the hands of the patients, right? So from your experience at Babylon, what are the things that made the transition hard, but which might not be obvious for the audience who are already convinced of the one-to-many, but who might not be seeing those pitfalls? Which ones would they be?
We can categorize in many ways. Let me start with the simplest one, which is, and this is often, I understand we have an international audience, but one of the things that's most challenging, let's say we have a centralized repository of, say, 30 clinicians that are available to see patients. And that's the group that's going to take care of a much broader population. Now, in the US, those clinicians are licensed only at the state level. So as I mentioned, I'm talking to everybody here from the state of Massachusetts. If I want to see or take care of a patient who lives literally a few hours drive away in the state of Connecticut, I cannot do that legally. So there is a situation, so that is a major problem where, in fact, in the US, you actually need a license in every single state in order to practice nationally. So those are the types of barriers that are more structural or policy related. If you can believe it, for cancer therapy during the pandemic here in Massachusetts, once that ended, people, if you were sort of taking care of somebody who was in another state, some people were actually having those patients drive to the border of the state, just park their car, get the care that they needed through telemedicine, and then drive back. So that's the kind of, those are some of the barriers. And that's just one, but there are many structural barriers like that. In particular, insurance types, where pharmacies are located. So there's an enormous amount of technical thinking that's been done around that architecture. So that's bucket one. Bucket two would be things that are scheduling related. So again, simply put, just queuing and actually creating a national network, and one where we actually can do scheduling across time zones. We have 30 clinicians. How do they know what hours they're working? What if one of them gets sick? How do you reschedule? Enormous amount of technical knowledge and architecture has to go into that. And then the final piece of it, in terms of the one-to-many, is that when people are triaged, even in that situation, we can't actually always predict how complex their needs may be at that time. In other words, somebody may need a 5-minute visit or a 10-minute visit. Suppose they just have a simple problem that can be addressed. And then others, when you start talking to them, you realize, wow, you see them on video. They've got a bunch of kids in the background. They have a scar on their face. You realize they might have interpersonal violence and other issues. The challenges of sort of addressing and metering that one-to-many, it's often just unpredictable. And obviously then, as a result, our schedules get messed up. People are unhappy. They may not get the care they always need.
Maybe one quick follow-up question on that. So you mentioned the word triage. Maybe we'll come back to that later on. At Babylon, at what points in the care journey do you do triage? Is it kind of like a continuous triage that is helping to make these priority calls, or where does that exist, and how is that working?
So it's done in a couple of ways. So the first is, for those of you familiar with Babylon, when you log onto the app, there's a number of options. You can have digital sort of advice given through our triage platform, or you can make an appointment or send an asynchronous text message. So those are the ways in which communication is initiated. We also have outbound calling that are triggered as well. So for the digital triage, you can say, oh, I have a headache, and it'll go through and interview you and then make a recommendation on the level of care that you need. In some situations, it could be self-care, and then that ends at that point. So that is what, several, a significant minority of people just after the self-care will then just take that advice. On the other hand, it could say, well, you have a headache. It might be due to sinus infection or something like that. Would you like to make a non-urgent appointment? So then it allows you to then make an appointment. And then in some situations say, wow, your headache sounds like you might be having an intracranial hemorrhage or something like that, or meningitis. Don't even talk to us. We recommend you call for an emergency care. So that's the first. The second is then people can actually just text in or message in what their particular needs are. In that situation, then that's looked at by our care manager on the other end, and a prioritization decision is made. And then, then they'll prioritize: do they need an appointment? Can this be handled asynchronously or not? Those are who do that kind of triage.
So last drilling down on this thing, was something that you said. So if I understood correctly, so a significant minority of people will follow up on the advice given after self-care flow, let's say. Can you explain that a bit more? Why would that be? Because it seems to me that in a one-to-many model, right, increasing that percentage of people who will indeed follow up on that advice is actually a great way forward, right? It's a key to the solution.
Yep. Sorry. Say that again, Thomas. I didn't totally understand your question.
Yeah. So if I'm correct, what you said earlier was that after following a self-care flow, let's say, or a self-care process,
yes,
a significant minority of people will follow up on the advice that is given to them. Is that correct?
Yeah.
You said that?
Yes. Yeah. So what I meant to say, I apologize. I don't think I was being very clear. In those situations when the triage, the AI, it's a Bayesian belief network is sort of the approach we use for that. It will sometimes triage them to say, we think you have a low acuity issue. So what I meant is let's say 100 people go through that flow, a significant minority, maybe 10, 20, 30% of them will be directed toward just self-care. So they can avoid an appointment and just self-serve. That's what I was referring to. As opposed to others would say, we're not sure, let's make an appointment to see you. So the idea is to reduce that. So rather than having 100 people have appointments, we may have 50 appointments with us if they go through.
Maybe a question that I have, Darshak, is you've touched upon a lot of things that you're doing, for example, the triaging that is probably successful, but you also did experiments that just failed when it comes to scaling to a one-to-many care model, and which did fail.
So I think, Rick, you bring up a good point, which is it's tempting for us just to tell the stories of our successes and not so often to tell the stories of a lot of our failures. Let me give an example of an area where and I think it's fair to say we're still figuring this out, which is one of our thoughts was that we would be able to, people, when they had the ability to self-monitor a number of their own conditions, like because we encourage wellness in addition to acute care. So we have a product in our app called My Health, which is essentially like Apple Health, or allows people to monitor on their own weight, blood pressure, glucose, and a number of other, we have a few dozen items they can monitor. We believe that this would be a very popular feature, particularly among individuals who hadn't had access to digital health before. We started that market in the US and then went to the UK. And what we found is that while we spent actually a fair amount of resources building out a beautiful app experience where where people could track that, the actual uptake was actually quite low for those particular set of features. And what we found is that people in general don't just want to track their weight or track their pulse or their blood pressure, but rather they need the connection with the clinician first to understand the trajectory of their health, and only then sort of work with them with remote monitoring solutions of some type. It turns out the number of people that are really kind of into tracking all their metrics and everything is actually a really, really small number. And we're a risk, I didn't mention this before, we take full risk on large. We have about 300,000 members. So we can't just appeal to people that in a consumer directed way, but we have to create a product when patients are assigned to us that a large majority of them will actually use. That's been the big challenge for us.
This also touched upon a bit like patient engagement, which is also very important when scaling to this one-to-many care model. So how do you currently build engagement in a digital platform that is built for scaling? And patients are not always willing to, for example, fill in these 10 minutes pre-consultation assessment.
So let me give an example. So when we a little bit of background about our business model. I think the audience might find this interesting. So as many people are aware, Babylon began in the UK as digitally enabled primary care in the NHS. And over years built up a whole approach to delivering comprehensive primary care. Now, the thing in the UK is that there's really, the NHS just gives a primary care capitated fee per year. So in other words, for every member that chooses Babylon, we were getting paid a fixed amount of money to handle all their primary care for a year. The thing many Americans are shocked by is the amount of money that is. It is about roughly, give or take, $150 per person per year. So now what that means is that if we create value and see patients and reduce like downstream hospitalizations, all that, we don't get the benefit of that. In fact, there's almost like in the NHS, a disincentive to do a lot of care. That's why waits are so long, because there, again, the benefit doesn't accrue to the actual provider. So there's no sense of value-based care. It's one of the reasons Babylon moved the model to the United States. The first market in the US, we took a full risk contract in the state of Missouri. 20,000 roughly patients were attributed to Babylon in Medicaid. And for some of your listeners, Medicaid in the US is typically health insurance for low-income individuals. And it also, some states are much more restrictive in who they allow to have it compared to others. Missouri is one of the more restrictive ones. So we inherited 20,000 patients, a lot of them children and young women. That was the age. And then they just gave us a list. And you can imagine that organization, who are they going to give us their risk on? These are the patients that are the most challenging to reach. They don't have phone numbers, they don't have addresses, and yet we are financially responsible. So that was, sometimes when you first enter a market, you have to take challenging populations. So in a very real way, the challenge we were trying to surmount is, how do we get 20,000 people that have not engaged in care sign up with a company they've never heard of with a name like Babylon and actually come to us for their primary care? So that was the problem we started with. So we actually spent, this was about 2 years ago, an enormous amount of time and effort. We had people we hired to knock on doors. We advertised on billboards. We tried to hire companies to find these patients. And we've reported this publicly. It took us about 2 years or so to get maybe about a third or so of the patients to download the app and register. So that was our learning curve. Then when we went on our new markets, we actually were able to make that half that amount of time because we got much smarter. But then we realized that engagement is really challenging in places like Medicare and Medicaid because there's no way to drive members to use a digital first platform. So just this month, we have now launched a commercial plan on the exchanges. That is the best analogy for the NHS in the sense that people have to come through us for their digital first care. And that's been incredible. Like, they're engaged, they're motivated, and we're finding that even more rapidly we're getting their engagement. We just launched on January 1st. So it's been quite a journey, and engagement continues to be a real challenge for not only for us, but for any digital first organization that's trying to do value-based care.
Yeah, so I think indeed when you take away that relation, that human connection, right? The obligation, to show up to the doctor, even though in the physical world you have no shows, etc. But if you take that away, there's even less incentive to stay engaged, right? And so I'm not asking you to give away all of your learnings here, but could you tell us, during those 2 years where you activated, part of those 20,000 initial patients, what is a learning that could be relevant for others who are dealing with the same issues?
Yeah, I mean, it's really, in retrospect, it's pretty basic, but it takes us a while to understand this. And the simple thing is, you have to give people something they want rather than outreach with something we want. So a simple example is, let's say, some of our contracts, there's some risk that's based on our quality scores and quality outcomes, like HEDIS metrics in the US, QOF metrics in the UK, and so forth. And so one can do an outreach broadly on a digital platform and say, hey, you should have your mammogram or your pap smear, or please get your COVID vaccination. We found that did not result in a lot of uptake. Again, that's not surprising, right? These are individuals, often, I mentioned the Medicaid population, They have a lot of other things to worry about, everything from transportation to income in the home, how are you getting your kids to school? That is not front and center. On the other hand, what we learned after a few months was we did an outbound campaign on getting people mental health care and saying we could get them. Actually, fully half of our US visits currently are behavioral and mental health. We have a collaborative care model and so forth. We found that had enormous traction because many people wanted behavioral health care assistance, both for themselves and for their families. And so, again, that was one learning where we need to simply say, well, what is it that you want? What can we help you with? And then they'll reply. So I mentioned behavioral health. The other really powerful engagement tool we had was whenever people called in, then I mentioned I worked on the accountable health communities. It's screening for social needs and then saying, look, thank you for letting us know. We're going to help you with this one particular need you've outlined. And that also is a really powerful engagement tool. Probably even more important than, for example, hey, you can monitor your blood pressure on our app in a cool way. So I'll say, last piece I'll say is that is learning. I've talked about Medicaid. We're really interesting things. We have Medicare populations as well. What motivates them is very different. So what we need to think about is a hyper-local strategy, maybe not hyper-local, but at least state-based or line of business-based. And we're finding that the things people want varies enormously. We just need to then understand and meet them where they're at.
Yeah, so I really love what you're saying because that's where there's a lot of similarities between DevOps and CareOps, because DevOps revolves first around, what is the business challenge or what is the customer need, the customer problem that we want to solve, and then create your software to deliver on that problem, right? And so the care processes that you should design through CareOps, right, should also answer the needs of your individual patients. Now, when you are a specialist care provider, whether that's virtual or physical, I'm not going to say that it's easy, but the problem with Babylon is compounded because you have different geographical models. You already mentioned fee-for-service versus value-based care, so we might get back into that one, right? So multiple geographies. There's Medicare, Medicaid. How on earth are you identifying the individual needs of these individual patients? Because that seems to be really one of the core keys to getting that engagement, and everybody's after that engagement. So how are you tackling that at Babylon to get to that individual need?
So there's a couple ways. So I think it's graded. So let me say that at Babylon, our core model is to have some way of collecting data on our patients, analyze that data, and then reach back or offer insights to them that encourages their engagement. So everything depends, simply put, on can we collect the data at the right place, right time, and analyze it in a way to surface those needs. That model, broadly to me, is reproducible in the sense that regardless of where you live, if we create the right models and risk stratification and insights, it doesn't matter whether you're a Medicare patient in New Mexico or a Medicaid patient in Iowa or a commercial patient in Georgia, that sort of internal brain should be applicable around that. Now, that's the theory. The challenge is that getting that data proves to be enormously complicated, particularly in the US. So even just getting claims data in some of our contracts has been incredibly difficult. Again, not a surprise to a lot of people who know US healthcare, but so when we don't have claims data, how do we stratify them? So I think in answer to your question, what we do is we have to then be really scrappy. So in Iowa, for example, have almost 80,000 patients that have been attributed to us in Medicaid. It's an expansion state, so at least we have it's a wide variety of needs. We've actually had to do on-the-ground events where we send our community teams in and to talk to people, say, what are the kinds of things that are going on here? Because again, in an ideal world, we have all the data, we hear it from them. So that's where we might hear, for example, last spring, as people are aware, there was a big baby formula shortage in the United States. That was something that's not going to show up in claims or anything, but when you're on the ground doing that outbound, you realize many people were having a lot of trouble getting hold of baby formula. So we did a big outbound campaign to engage people to say, well, we can help you get baby formula. As many of you might be aware of that. For example, in some of our populations in Missouri, where we did that, same thing. We didn't have a lot of data, but that's where we found that one of the biggest needs was going to be prenatal and postnatal care. Many people are pretty far removed. Only about 30% of patients after even delivering a baby in the hospital would come back for any care at all. Incredible. But they wanted that need. There was that need. So that's sort of how we had to do it. Actually, the truth is fairly manually in each of these areas. Now we're finally seeing the pipelines of our data get a little better. And so our hope is that over this year, we'll be able to use much more analytic approaches to actually doing that kind of engagement and outreach.
Okay. So I want to quickly touch upon very shortly because it's related to, but it's not the core of our discussion today. So it seems to me that what you're saying is that in a value-based care world, right? So let me ask this question differently. So you've built this triage system. You're investing in analytics to better understand the needs of your patients and to answer those needs. But there's no reimbursement code for that, right? Right. Are you saying that a value-based care model actually allows you as a company to experiment how to transition better into that one-to-many model versus a fee-for-service world where it's very difficult because you're taking on that risk? Is that creating much more flexibility to experiment with these models?
Yeah, actually, that is the approach for why we chose value-based care, because there's a couple ways one can go about building comprehensive digital primary care. If you don't have value, if you don't have, let's sort of look at the alternate universe Babylon would have to operate in if we didn't have value-based care contracts. As many people have realized, the patient acquisition cost, marketing, all of that work you have to do to break into physician networks, get payers to reimburse, that is such an enormous tax on an organization in order to do all that rather than developing the core models. So a consumer-first approach really, and then it also focuses even more on what I talked about, which is what is it that patients want. It is very rare for patients that are doing consumer direct programs to say, you know what, I want to manage my diabetes better, or my hypertension better, or my cancer prevention. Almost always consumer-focused products where it's fee-for-service are things that are going to be urgent care oriented, sexual performance, like all the companies you see exploding. Why? Because that's what people want. Value-based care, the reason one of the reasons I joined the company is that actually the onus for that, for broader sort of work on health falls on us, and it liberates us from billing for every single little code that we're being charged here. Because coding, rev cycle management, all that, just imagine the amount of resources you have to develop in order to actually do all that. So it liberated us from that to take our limited resources and deploy them much more on putting out the care models. Now, I'll say the price we pay is that engagement is a challenge, because we have 20,000 patients. How many of them are really coming to us when they have a question? How do we build that trust? That's the problem we choose to focus on, rather than how do we acquire customers for fee-for-service. So I hope that answers the question a little bit. So we're really committed to value-based care broadly.
Very clear, thanks.
Yeah. Another question that I have, Darshak, and I've seen that my friend Casey has the same. So I think the problem that we currently have with all the data is that it creates like a big influx of a ton of new data. And then this makes the problem or the data that clinicians need to look at much bigger. So my question to you is, how do you take all this data from, for example, the triaging questionnaires, and how do you make it actionable so your care teams can actually use the data? Is it with huddles? Is it with technology, or how do you tackle this at Babylon?
Yeah, I hope I could talk about Babylon, but also maybe pull on a little bit of other experience I had, just to give some context here. But by comparison, when I was at OptumLabs, we had claims on 190 million individuals for about 20 years, and we had about 95 million full text EHR records as well. I say that because this notion of data as a resource I think increasingly in the world we're in, data itself is a commodity. You can buy, you can get a hold of it. Having data is not what's going to distinguish us. In other words, what I'm arguing is we want to move from just knowledge to wisdom. The resource which is the hardest one to find is people who ask the very simple questions of the data to drive those insights. And this is, I feel very strongly, we talk a lot about AI and machine learning and random forest models and all that. And sometimes you literally just need to count things. So I'm going to emphasize that it doesn't take an enormous amount of computing power and very sophisticated resources to start to draw those insights out. So I'll just start with that. And then I would challenge both our own organization and others to say, let's move away from the shiny objects and just talk about AI to saying, what is the actual problem you're trying to solve? So having said that, I'll give a couple examples of the really simple data we use. So one of the things I mentioned, we found that mental health is an enormous contributor. And we find that when you address mental health, total cost of care is also improved. So very simply, what we put in is part of our enrollment process. In the initial engagement, we do a PHQ-9 and GAD-7, or PHQ-2, actually, even just 2 questions now, and GAD-7. So again, just simply gathering that data, that gives us a target and go-get list of individuals who have significant needs, and we push out resources to those individuals. So that's what our care teams and care managers would use as a go-get, for example. The second one, again, very, very simple, and I want to emphasize this, is we simply also just look at our ADT fees, like who's been admitted to the hospital. Those are going to immediately then, 20% readmission risk, but most importantly, gives us a sense of what the community resources are like, and those individuals are highly motivated. The amount of work to get that ADT feed from where it is to us, it's an enormous technical lift. We spent a lot of time on that as well. That also goes to our care teams, the localized care teams, and then they'll go through that list. And then finally, what we are trying to do now is, once we have that outcome data, we're using that to then build our models to say, can we predict who's going to be highest cost and highest spend? We actually have a bunch of models that have been in development right now, and then we're thinking about implementing them and seeing, most importantly, can we find out who's at high risk? But then what's the actionable insight that can come out of it? And our applied science team is working on that now. Yeah, it's quite a process.
So that basically ties in nicely to care ops, right? So going back, to your initial comment, the one-to-one model where there was high touch and all of those individual interactions, and then the care team could communicate on what is the next step for each patient, right? In a one-to-many model where you have self-care, where people are doing their own triage, when you're engaging all these people in different modalities and channels, right? How do you how do you define what is the best next step for every patient? And it's I'll tie it to one of the questions that came from the audience.
Yes.
Is it flow charts, or is it AI, or is it something that lives in between? What determines the next step for the patient?
Yeah. So the way we approach it, and the sort of reproducible framework I've used, not only at Babylon, but also at United, and even when I was in the federal government and before, was the first piece is having a broad-based sort of clinical understanding of the drivers of health in your population. So some of you are familiar with IHME, they do that internationally and nationally, the global burden of disease and national burden of disease. We take that approach and we localize that for each of our markets. So we develop reports in Missouri, everywhere else, and we simply just look at where the costs going and where are the needs of the patients based on claims and other data. What we find is that, as you can imagine, significant local disparity. So what we found in Iowa and Missouri, the number one diagnosis driving a lot of our costs was oppositional defiant disorder, which is basically children who have a lot of challenges with self-regulation. That would not have come out in any other way. But then the next step I'll say, let's take, and then the other one is in another state, we found it was neonatal intensive care, and then the first few months after discharge from the hospital. So we just start with that framework, which is, where are the problems? And that's not something that will come out any other way. We take the next step, and what I'm emphasizing is there's no real AI, so to speak, or data here, other than in the analytic work. Then what's needed is a clinical insight. In other words, for children of oppositional defiant disorder, or another big driver was asthma, what is the thing that we should be doing that we are not doing? And I think this sort of gets care ops approach. You need that insight, right? So for oppositional defiant disorder, it could be like, parents need some education, or they need some tools to approach, or they need an 8-week parenting course on how to handle a really difficult, a child who has really complex needs. So then we build those journeys in response to that. For asthma, another really good example, clinically, we know that almost any asthma admissions in a well-managed population should essentially be zero. The major issue is a lack of understanding of controller medications and appropriate use of controllers and asthma action plans. That insight comes clinically, but then we use that. We developed a journey and a set of clinical protocols that are both self-directed on the app as well as administered by our care team to do that one-to-many for asthma. But that's our approach, is that each market, I'll just summarize by saying we try to understand the major drivers of cost. We then direct our digital care teams and our digital tools to then develop a service that then addresses that specific need. And then we think, how do we increasingly digitize it? As you know, we probably start out pretty labor intensive. So we try to learn iteratively, and we just kind of throw people at it. Then we learn, well, oh, this could be automated. We can do this by Braves. We can do this by app alerts. Oh, we can do this through automated reminders. We can do this with care assistants. And that's the virtuous cycle we try to push on.
Yeah, so that's great, and that's perfectly in line with the care ops model, right? And what I think is interesting for the audience is, given a certain program, right, that might start out quite labor intensive, and then the end goal is to automate as much of it, yes, and to be in a one-to-many state for as many patients as possible. Yes. How often do you typically iterate on that process at Babylon? So let's say that my V1 that is labor intensive is live today, first patients today. How many times will you have iterated on that by the end of the year?
Yeah, so we about a year ago started a program that we called we identified 12 specific conditions that we wanted to focus on, informed in part by the epidemiologic and sort of claims analysis work we did. And it was things that people can relate to, cardiovascular, pulmonary, endocrine, and we identified the disease areas. And what we did was, I'm even just thinking of, for example, for type 2 diabetes, we made a list of the 30 things that we should be doing for somebody who is at risk of type 2 diabetes or has it. Referral to diabetes prevention program, initial screening, hemoglobin A1C, nutritional counseling. We made that whole list of all of that. In an ideal setting, what would that care model look like? And what we did then was we said, okay, what are the 2 things we should be doing now? And so the first one we just started was we just need to identify an at-risk population. And we said, if they have prediabetes, we'll refer them to a diabetes prevention program. So in other words, we didn't do the 50 things on that list. We just did 2 things. But we did that across all 10 condition areas. So the learning, we typically will then iterate on a every 2-month basis or so. What we found, for example, was rather than building an entire complete program in diabetes, we did this widely. We found, for example, that in COPD, there really wasn't that much sort of uptake, and even our population wasn't really that engaged. And so building out a whole program would have made a lot of sense. On the other hand, we did get, some uptake in our, as I said, mental health, and then particularly in pregnancy care, transitional care management, and a few others, because enrollments were coming in. We then would add out and build things and pick them off that list to build that out. So that's sort of our approach, is we're trying to build where our members are telling us they have their needs, if that makes sense.
Yeah, maybe I think the final question, it's around standardization. So as we all know, making sure clinicians follow standardized protocols is painful. It's a common argument that they use is that they are creative thinking individuals and they're not robots,
Yeah.
and they don't want to follow standardized protocols.
Yeah.
So have you found success in getting standardization among these providers on the ground? And if so, any learnings that you can share with the audience on how to get adoption when it comes to standardization?
Yeah. Let me give one example. So just today, our team did a US-based grand rounds on our standardized approach to smoking cessation. And what I'll say, Rick, it's a really good point. And I think my sense is it's not that clinicians don't like being told what to do. It's that the direction they get is super confusing and really just not clear, and the tools aren't there. So I'll give an example with smoking cessation. So with that, there are probably 8 or 9 different pharmaceutical agents on the market for nicotine replacement and cravings for like bupropion and others. The challenge is that there's no clarity what should be your first line therapy on that list of 8. We don't tell people. The guidelines just say, one of these. The same is true in type 2 diabetes. You look at the anti-hypoglycemics, there's metformin, but then second choice, it's unclear. American Diabetes Association and others, it's very, very challenging. So in our view, what we do is we believe that clinicians want to do the right thing and they want to practice evidence-based care. The problem is we haven't developed the simplified tools to help them do that. So what we've done is, simply put, our backend EHR that we use at Babylon, we've done a lot of technical, we use Athena. So what we did, simply put, after we had that meeting, we then are going to take the templates and then we just create a simple Athena protocol for this. We've agreed as an organization, this will be our first line therapy for nicotine replacement, for example. And we, again, simplify that. We have a whole knowledge base so that when people have to refer to it, they know where it is. I'm much more optimistic. I don't think clinicians are that independent and feel like they all have to be super different. But in these areas, we can have some consensus.
Maybe just to quickly follow up on that one. So great that you are able to take a guideline and then really implement it into your tech stack. In this case, Athena, you update that template. Are you then able to close the feedback loop and to say, okay, for this cohort of patients, those were the patients where that first line therapy was adapted. How can we now compare that to another cohort to really start informing that continuous loop of getting back to your processes and update?
Yeah, it's a great question. I would say that in some areas, honestly, we have to just be satisfied with the process measures, because the outcomes, the numbers may not be enough to truly. Let's take statin therapy, right? Like there's many different statins for control of cholesterol. Obviously, we're on them because we want to prevent stroke and heart attack. But for every 100 people we treat perfectly with statins, the number needed to treat is about 50. So we'd have to treat thousands of people to detect a slight difference in heart attack and stroke rates. So instead, this is the whole concept between having process and other measures, is that the outcomes are so, it's just, and you don't want to get a bad signal. So that's sort of what our approach is. Yes, ideally, we would look at how many people stopped smoking or how many people didn't get lung cancer. Instead, we have to satisfy ourselves by saying, okay, of the 100 people who we at least have a code for smoking cessation, how many of them did we get a medication on? And then if we're lucky, we'll get a warm connection to see did they even fill the prescription. That's sort of where we're at this point, to be honest.
Okay, well, I think that's a very, very good one and a very high note to end on, Darshak. There's many other questions also from the audience, but as usual in these CareOps events, we might end with more questions at the end than we've answered. I think there's a lot of insights and very practical things that we got through this conversation today. Before we part ways, maybe one quick announcement. Obviously, we're not done with our series of events with CareOps, so the next one is planned for February. We're really happy to have Sofia Guerra in a hangout, who's an investor at Bessemer Partners and who wrote extensively on benchmarking technology-enabled service providers like Babylon, how to look at gross margins, how to improve your P&L and profitability ultimately. And I think that's on the mind of a lot of people, also something that goes to the heart of CareOps, because as you run through that CareOps life cycle, the goal is to bring your cost of care delivery down, which makes you a profitable company in the end, whether that's in fee-for-service or in value-based care models. So with this, thank you, Rick, for organizing again, tying everything together. Thank you, Darshak, for your time, to the audience as well. And hope to see you in February.
What a pleasure to see you all. Thank you so much for your time.
Bye, everybody.